So, good morning, everyone. Thank you for joining us. My name is Mark Paris-Condola. I'm the Director of the Research and Training Branch here at the NCI Center for Global Health. Thank you for joining us today for our Global Cancer Research and Control Seminar Series. This seminar features talks by researchers and cancer control experts working in global oncology and provides opportunities for discussion and collaboration on impactful and innovative work addressing cancer morbidity and mortality worldwide. Today, I'm delighted to welcome Dr. Ritesh Mistry. Dr. Mistry is an associate professor of global public health at the University of Michigan, and for many years, he has led public health research projects in the US and internationally addressing health risk behaviors, and particularly behaviors associated with cancer and chronic disease risks, such as tobacco use. So today, Dr. Mistry will characterize the neighborhood tobacco environment impacting adolescents in India, particularly focusing around tobacco retail access, promotion, and policy compliance. And we'll also examine the association between these neighborhood tobacco environmental factors and the risk. Please save your questions for the designated Q&A time immediately following the presentation. You may type your questions in the chat box or use the raise hand feature at that time. And secondly, also please note that today's presentation is being recorded and will be available afterwards on our events website at events.cancer.gov, and you can see the full URL here on the slide. Just as a disclaimer, please note that the views expressed in the following presentation are those of the speaker and do not necessarily reflect those of the National Cancer Institute, National Institutes of Health, the Department of Health and Human Services, or the U.S. government. And so now we will begin our presentation. So welcome, Dr. Mistry, and I'll turn it over to you.
Great. Well, thank you so much for that wonderful introduction, Mark. I'm again Ritesh Mistry. I'm representing my research team of collaborators from a variety of institutions here at the U of M, but also UCLA, which is where I got my doctoral degree. And we have also partners in India that I'd like to highlight at Helis Sexaria Institute of Public Health and Tata Memorial Center. They're both located in Mumbai, India. So today I'm going to talk about the neighborhood tobacco environment in India and kind of describe it, characterize it, and share with you some of the data that we've generated over the last decade or so, trying to understand the relationship between neighborhood environments and adolescent tobacco use in the Indian context, particularly in the city of Mumbai and also Kolkata. So my collaborators are, Dr. Prakash Gupta, Dr. William McCarthy, Mangesh Bednekar, Namrata Puntambekar, Trivalori Raghunathan, Surinder Shastri, Shamila Pimple, and Gauri Mishra. This work that I'm presenting today has been funded by a variety of institutions, including the NIH, NCI, but also the Fulbright Nehru Scholar Program and the UCLA Johnson Cancer Center. I declare no conflicts of interest in the material that I'll be sharing with you today. So just a basic outline of things that I'll cover today. I'll talk about just tobacco use in India in general in terms of prevalence rates and things of that nature. Talk about some relevant tobacco policies in India to youth that we examine in our work. I'll talk a little bit also about why it's important to think about social context and tobacco use. And then we'll talk about the studies that we've done over the last decade or so, providing some evidence on the importance of addressing context when we try to prevent and control tobacco use, particularly in young people. I may speak a little bit about future directions. Most of the work that we've done in India is focused on adolescent populations. And if you've been keeping track of tobacco use rates in India and young people especially, they've gone down dramatically. And what I believe and my team believes is that uptake and initiation is now starting later in India. So young adult, early adulthood, emerging adulthood populations are also things we'll need to consider as we move forward in this area of work. Um, just a little background on tobacco use in India. About 250 million people aged 15 and older in India use some sort of tobacco. Um, and that is about 21% of the adult population using smokeless tobacco products. And that is the most commonly used type of product in India. That equals to about 220 million people using smokeless tobacco products. So when you think about tobacco prevention and control in India, you really need to think about the type of products that are being used and the ways they're being used. And prevention and cessation programming and services have to be tailored toward the tobacco product type. So smoking tobacco is actually much less common in India. 7% of adults are smokers. And there's a huge gender difference in both smokeless and smoking tobacco use, with males being much more likely to use smokeless and smoking products. So 7% of adult smokers translate to about 74 million people in India who smoke. And just generally speaking, there's a huge geographic variability in tobacco use in India, as well as socio-demographic variability, particularly around variables such as religious identification and socioeconomic status, and of course, gender. Um, just to give you an idea of how tobacco use rates differ across the different parts of India, this was an interesting study done in 2002, describing the rates of tobacco use in different states in India. And if you just kind of notice, generally, uh, uh, use rates for smokeless products are much higher in the eastern part of India relative to the west, and rates seem to be somewhat lower in the northern and southern states of India. Okay? So if you think about high need uh, parts of the country, focusing on the eastern and western coast is probably a good idea, particularly when you think about male populations. And then when you think about smokeless tobacco products, it's much more common, again, in the eastern part of the country relative to the rest of the country. Our studies have focused mostly in Maharashtra and also West Bengal, which are two states bordering the western and eastern coast of the country. Um, Now, there are an estimated 1.23 million annual tobacco-related deaths in India, and this equates to about 18% of tobacco-related deaths worldwide. So India shares a large burden of tobacco-related disease burden and death burden in the globe. So I think it's a high priority area in terms of thinking about tobacco control and its cancer and other chronic disease consequences. Um, Now, I mentioned to you earlier that there are a variety of different products that are used in India that we probably don't see much in the Western or North American context. So I'm going to go through some main uh, types of tobacco products that are available in India. And so some of the Indian folks in the audience will be well aware of this, but some of you may not be. Well, one common way of consuming tobacco is called a pan, which is a betel leaf quid stuffed with a variety of different products, including tobacco, areca nut, flavorings, slate lime, and it's usually consumed after meals. But people who are habitual users will use it throughout the day. And so this is the one on the left is kind of a handmade version that you can get at many kiosks on the streets in India. And this is a manufactured version that kind of is mimicking the type of flavors you may get in the hand rolled version. And those both versions are very, very commonly used among tobacco using people in India. Um, Another common type of product, although it is banned in many parts of the country, is gutka, which is another form of manufactured tobacco product. And it's known for having a variety of different flavor offerings, and also a culprit of maybe early oral and esophageal cancer consequences of using this this highly addictive and dangerous product. That's why I think it's banned, but you can still purchase it readily in many parts of India. Another common product is Mishri, which is a roasted and ground up tobacco product. It's no other ingredient in this product. It's just pure tobacco, and usually it's not chewed, but it's applied to the gums. And one of the misconceptions in many people in India is that tobacco could serve as a dentifrice, an agent to clean and strengthen your teeth. So often people will use this product in the morning and rub it on their gums and mouth area. It's much more commonly used in female populations compared to male populations. Um, uh, Now, this is a surprising product that if people don't know what happens in terms of tobacco product availability in India, this is a tobacco toothpaste. So tobacco has sometimes been used in things like toothpaste, and people use this to clean their mouth in the morning and after meals. Um, and of course, people have here heard about probably BDs. They were even popular here in the US in the 90s, I would say. And they're hand rolled little cigar like products that are smoked. And this is a very cheap product, inexpensive product, and primarily used by low income populations. So these are some of the India specific type of products, but again, there's cigarettes are available in India, cigars are available in India. Also, e-cigarettes, though they are not allowed, can be purchased in India. So newer products are also coming into the marketplace. Uh, uh, Products like snus and oral nicotine products I don't think, have infiltrated the market much, but are interesting new type of product category that needs to be examined in the Indian context, especially considering some of the harm reduction potentials of those products as a substitute for things like pan masala and gutka and mishri and things of that nature. Um, Now, tobacco control policies in India. India was an early adopter of the Framework Convention of Tobacco Control. I think that was passed in India in the year 2003. And some of the main strategies that the policy tries to implement is things like reducing access to tobacco, especially to young people, restricting marketing of tobacco in retail environments, on billboards, on film, on television, and all of those types of spaces, and then also reducing secondhand smoke exposure. Of course, there are some other policies around cessation and education around tobacco, but these are some of the main policies that we've kind of been focusing on in the work that we've been doing in India for the last several years or a decade or so. Um, so in terms of the youth relevant policies in COTPA, which is the way people describe this act, Cigarette and Other Tobacco Products Act, or the Tobacco Act is another way people may describe this act. And this act has been amended numerous times since the implementation back in 2003. And some of the relevant provisions of that act that we've focused on is the prohibition of the sale of tobacco within 100 yards of educational institutions. Again, this is a national policy, so it covers the whole country. Uh, uh, Prohibition of the sale of tobacco to persons below the age of 18. This includes placing, a sign at the retail location that it is not legal to sell tobacco to people under the age of 18. Prohibition of direct and indirect advertising of tobacco products, including at retail and point of sale locations. Um, so this has been some of the focus of the work that we've been doing in India, these policies in terms of their implementation, compliance, and their effect on tobacco use risk in young people. Um, this is in terms of social context and tobacco use. Environment is a major influence to any behavior, including tobacco. We've all kind of come across a variety of different, theoretical perspectives that kind of guide our thinking around this, such as social cognitive theory or Bronfenbrenner's theory, and so forth. But the basic idea is, our context, where we live, influences our behavioral choices and the behaviors that we take on, including family, school, our work environments, our neighborhood environments, and beyond. And that's kind of the perspective that our studies have taken. And the idea here is to think about environmental factors as modifiable factors. Social cognitive theory talks about context shift. So how do we shift context into a more healthful context so individuals in that context make more healthful behavioral choices? So that's the basic foundation of where our work has come from. And just to give an idea about the conceptual model that we use in our work, is that we are examining and characterizing very in a nuanced way the neighborhood tobacco environment. And some of the areas that we consider in the environment are things like the density and access to tobacco retailers and advertisements in the environment. And we also consider compliance or adherence to laws that regulate the environment, like sale laws, marketing laws, and smoke-free laws. And these environmental factors we have hypothesized affect tobacco use risk in individuals, such as initiation of experimental, current, uh, and uh, and habitual use, as well as, which I have now listed here, susceptibility use, things like intention to use and curiosity about the product and things like that, uh, should be, and we anticipate would be affected by these types of environmental factors. But again, we have a family environment that could moderate this effect, right? Parent tobacco use can enhance the effect of the environment. If parents are not using, they could mitigate the effect of the environment. Homes have tobacco use policies, so we examined those policies in our data, whether tobacco use is allowed in the home or not, and where it might be allowed if it is allowed in the home. We also consider parenting style. As we probably all know, parenting in terms of monitoring and can be protective, whereas permissive parenting can be more harmful. So we examine those types of variables in the parent environment. And we also look at household SES. And we believe that the tobacco environment would operate in increasing tobacco use risk by these type of mediating factors, like uh, knowing where to buy tobacco, perceiving that tobacco is easy to get, being exposed to advertisements can normalize tobacco. Perceptions about how normative tobacco use are in peer groups. So these variables we've all collected in our data sets in India, and we're have been examining many of them, and we have still a lot of work to do in uh, doing all this analysis and writing it out. So just give you a highlight of some of the youth studies that we've done in India and some of the results we've presented from our data. One is we started with a pilot study in Mumbai. This pilot study was a feasibility study to see if we can actually collect the youth data, the environmental data, and try to assess, what is the prevalence of tobacco use in high school students in India and related factors, understand the neighborhood density of tobacco retailers and advertisements, assess the compliance with COTPA provisions that are youth relevant, which I've mentioned earlier, what factors would be maybe associated with compliance, retailer compliance, and whether there are any associations between retailer density compliance and student tobacco use. And we use these pilot data to then inform a longitudinal study later on. So I'm going to present some data from this pilot study and then also then from the larger follow-up study that was based on this pilot study. And again, this pilot study was conducted in Mumbai. And for folks who don't know, Mumbai is a major metropolis in the western coast of India. kind of gives you an idea of where it is here in the state of Maharashtra in the Indian subcontinent. Um, the approach we took is we did a population-based tobacco use survey of high school students in Mumbai. So it was a two-stage cluster sampling design where we sampled schools, high schools in India, and then the second stage sampled classes in India, in classrooms in that school to collect our data. And this data are based on 26 schools and 1,533 students. And what we did next was once we identified the schools in the study, we characterized the neighborhood environment around the school. So we mapped out all the tobacco advertisements, retailers using field GIS data collection procedures. And we basically went through an area which was 500 meters walking distance on the street around schools. The difficulty in India back when we did this pilot study, and still today, is there's no real retailer licensing. So there's no list that the government keeps of people and businesses that are selling tobacco products. So if you want to do this type of work in the Indian context, you really just have to go out there and walk the neighborhoods and identify these using field researchers. Um, in the U.S., when we've done studies similarly in the U.S., we get them from the tax board or the state board, which keeps track of, especially states that have a retail license in law, that keeps track of all the retailers. But in India, we don't have that information, so we have to collect it ourselves. So after we get a sampling frame of all the mapped advertisements and retailers, we sampled about 400 retailers to do compliance checks there by doing observations of the retailer environment, but also then speaking with the retailer about tobacco sales in their store. So it was a relatively large pilot study, uh, but highly informative in my view. So these are some of the folks in our team collecting the data, and we used the handheld computer device, not a smartphone or iPad or anything like that, to do this study, where we programmed this device to capture the data that we wanted to capture. And just to give you an idea about the how concentrated the retail tobacco retailer environment is in India. I mean, on average, we found that there were 62 retailers of tobacco within 500 meters of schools, which is a large number. In California, when we did a similar study with high schools using a retailer list we got from the state of California, we found 11 retailers within 1 mile of a school. That's 1,600 meters. So you can just see the immense difference you may see from like a North American urban context or a state context versus what we see in India. And 8 retailers within 100 miles of schools. This was actually after the policy was enacted that you cannot have retailers within 100 meters of schools. So there's a lot of non-compliance with this rule. Um, and just to give a flavor to the audience about what the retailer environments look like in India, the majority of retailer environments for tobacco tend to be these shops, well, what are called general stores in India, which are like small convenience storefronts where you can buy many different products, chips, soda, bread, eggs, but you can also buy tobacco. And if you notice here, there's the kind of a string of pouches here, and those are tobacco pouches being sold right next to chips and right above candy and soda pop and ice cream. Product placement is something that also could be regulated in India, and I think should be regulated, that you keep the product maybe in the back somewhere that's away from uh, uh, from that's not visible to the public, but also not next to things that children may be more likely to buy. Um, and these are some examples of street vendors in India, which also make up a large proportion of retailers, and these are much more difficult to regulate. Uh, so you will see a small stand pop up on the sidewalk or on a wall, and when the person leaves for home, they will uh, lift up this bottom table and close shop, and the next day open it again in the morning to start business. And when we walked the neighborhoods, these were not moved. These are semi-permanent locations uh, in that neighborhood, right? So most tobacco is being sold in these types of places, and you also sometimes notice that youth might be selling tobacco or going to these types of places. So that's something to be mindful of. So in terms of tobacco ad density, we found about 16 advertisements when we did this study within a 500-meter of schools, and about 2 advertisements for tobacco within 100 meters of schools on average in Mumbai. And just an idea about what these advertisements may look like. Now, when we did this study, the rules were a little different around tobacco advertising. You could have 2 ads at the retailer location, and those ads had to meet a specific size criteria and content criteria. And this ad here on this storefront is massive. Uh, but this the industry may not consider as part of the advertisement, although this is kind of the branding, the gold flake branding, and they're skirting the rule. This is meeting the size requirement here, but the rest of it is not. Similarly with this particular ad, and ads are not supposed to have images of men or women or anything like that, but here you do have some images of that. Here's some flyers for the ads. And as time has gone by in the last 10 years, there have been a lot of improvements in terms of implementation and compliance with these advertising rules. One, the rules have changed now. There are no advertisements allowed at any retailer location. And so as a result of that, we're seeing we don't see too many of these types of ads anymore. Um, so which is good, and we believe that some of the work that we've done and our work has been cited by the government to ban these types of ads in India. This is an analysis of the effect of ads and retailers on tobacco use in students in our sample. So we did find that advertisement density increased the risk of experimental use of tobacco. So this high, medium, low categorization, we took the density within a neighborhood and uh, tertiled that density into 3 groups: a low, middle, high group, and the referent group is low. So if you have a medium concentration or high concentration of ads relative to a low concentration of ads, there's a higher risk of experimental smoking, and also a higher risk of past 30-day smokeless tobacco use and past 30-day any tobacco use. We were not able to examine smoking tobacco use separately because the sample sizes for that use pattern was quite low. And these analyses are adjusted for a variety of different uh, sociodemographic and psychological factors like peer use, perceived peer use, hopelessness, and perceived ease of access to tobacco. Um, and in terms of compliance, we found relatively low compliance to tobacco control laws at that time. We found that overall only 3% of retailers complied with all the rules in tobacco, and much of that is driven by having a signage that says it's illegal to sell tobacco to minors. This first row of data, 80% compliance uh, the ban on selling tobacco to minors was self-reported. We did not do purchase attempts to do this work. It's self-reported, so I imagine this number in reality is much lower. Most tobacco retailers had less than 2 ads at that time, and most met the size and content requirements for those ads. But to be fully compliant was quite rare in the retailer sample that we examined, which was a population-based sample. And when we examined the impact of compliance on tobacco use, we did find that higher compliance, so we broke up the compliance data, which was basically the percentage of retailers that were compliant to rules in 4 groups, quartiles, and the most compliant neighborhoods had kids who were least at risk of current tobacco use. And this again was adjusted for a variety of different factors. So using this information, we applied to the NIH and said, hey, we would like to do a more rigorous study. The previous data were cross-sectional data and in one city, so maybe not as generalizable or as relevant for causal inference as might be other types of designs and samples. So we proposed a longitudinal study of adolescent tobacco use in India, where the main goal of the study is to estimate the association between neighborhood tobacco environmental factors, such as retailer access, marketing, and secondhand smoke, related rules, and also exposure on adolescent tobacco use in the context of family. So what I'll focus on in this presentation is some of the, not the baseline information, but the association between neighborhood tobacco retailer access and tobacco use susceptibility. And the methods we used were somewhat similar in that we had a population-based sample. And this time we did not sample from a school-based population. We sampled from a community-based population. Our thinking was that in India, about 60 to 70% of school-aged kids actually go to school. So some of the more high-risk youth are actually not attending high school, and they're doing other types of things like working. So we felt like to understand youth better, we need to have a community-based sample and maybe not use a school-based sample. Thinking about this going in the future, I would probably do both in the future, because collecting tobacco use or any substance use data in the home of a child is quite difficult. And I think there is a social desirability bias that affects reporting of those types of behaviors when you collect data at the home. And we find that this happens also in some of the US data that we've looked at in terms of the PATH study, for example, Population Assessment of Tobacco and Health. It's a home-based sample, and those data usually show that the rates of use are lower in youth populations than something like MTF, Monitoring the Future study that collects data from a school-based sample. We used the Government of India's National Sample Survey Office's Urban Frame Survey as the sampling frame to identify the neighborhoods that we would work in terms of data collection. And then we enumerated all the households in those neighborhoods after we sampled them to create our frame for the household sampling part of the study. And we weighted our survey so it's representative to each city individually. And we did interviews with both parents and adolescents using a computer-aided system. Part of the survey was self-administered, and the sensitive questions were using an ACASI approach, which is audio computer-assisted self-interviewing to lower social desirability bias in reporting of tobacco use behaviors. And then in the neighborhoods we sampled, we used GIS to collect data on tobacco retailers and public places We also examine public places to assess compliance with smoke-free laws in public places like restaurants, schools, hospitals, railroad stations, bus outlets. And then we also examined all types of tobacco retailers to see if retailers are compliant with retailer related laws. And we did random checks at these locations to assess compliance in a sample of locations, a representative sample. This map is a map of Mumbai and Kolkata, just to give you an idea about the geographic coverage of the longitudinal study. This is kind of the metro part of Mumbai, and this is a suburban part of Mumbai. And you can see that we have very decent coverage in terms of the neighborhoods across the city. And here is Kolkata, where our neighborhoods are. Kolkata is a little bit more compact, and these are where our neighborhoods are in Kolkata. And it's relatively good coverage, maybe not so good in the southwestern part of the city. So I think we believe that our data are city representative uh, uh, in terms of the results that we present. This gives you an idea about the density of tobacco retailers in the neighborhoods in our sample across the uh, 52 neighborhoods in both cities together. All right, this is each yellow dot is a retailer, and this area is about a 1 kilometer square area, each of these. And this is what a high density area looks like, a middle density area, and low density area. On average, uh, let's see, well, we found 5,000 tobacco retailers across the two cities over one wave of data collection. We did this data collection twice. I haven't reported the second wave of data collection in terms of the neighborhood data. Um, we found 8,000 retailers in wave two of the neighborhood data collection. So actually retailers increased as time went on in our study. On a mean, there were 97 outlets within this 1 kilometer area, and there were more retailers in Mumbai versus Kolkata on average. Okay, and here I present the compliance data across these two cities around the youth relevant retailer rules. Um, yeah, so this was an observation done. No tobacco sales to minors and no tobacco sales by minors observed by our field investigators. They would spend about 15 minutes in observing the retailer from a distance to see if somebody who looked like a minor is purchasing tobacco. And actually, compliance to these two rules appeared to be high from the way we collected that data, but ideally, we would do purchase attempts to get at this information more directly. We found that 77% of retailers were compliant with the rule on not being located within 100 yards of schools in Mumbai, and the rate was a little higher in Kolkata. 50% of retailers had no tobacco advertisements in Mumbai, whereas the compliance was a little higher in Kolkata. And there was almost no compliance with the rule on signage being present about the ban on sale to minors. And that's, I think, an important rule to have in place and be complied to, because it does communicate not only to the retailer, but also to the purchaser that they may be engaged in an illegal activity if they're a minor and selling tobacco to a minor individual. So what we did was we examined not all these laws in terms of their relationship with our use outcomes or susceptibility outcomes, because there was actually really little variability in the sale to or by minor measure and the signage measure, but there was adequate variability in terms of the location measure and the advertisement measure. This data again is the percent of retailers that are being complied and the number of retailers, and this table presents the neighborhood level rates of compliance. So you do see that there is a large variability in terms of the two measures we examined subsequently for associations with tobacco use and susceptibility risk. Some as low as 45% in some neighborhoods, or as high as 100% compliance in some neighborhoods for this location rule. Time is running out. And this is our susceptibility information. I guess what I want to emphasize is that we actually found very few adolescents who reported tobacco use in our study. I think part of it has to do with the context of data collection, that it being in the home. So we were relegated to using these susceptibility measures at this point as our outcomes. And these types of susceptibility measures, like ease of access, perceived peer use, and intention to use, have been shown in the literature to be consistently positively associated with tobacco use in the future in young people. So we examined whether compliance to the location rule and the advertisement rule reduce the risk of susceptibility. And this data shows that comparing Mumbai and Kolkata, we see that as there's higher compliance to the school proximity rule, there's lower risk of intention and perceived uh, peer use. And this measure of retailer visit index is a measure that measures how often these kids go to a retailer that might be selling tobacco. The four most common retailers we found in our data set: general stores, street vendors, tea stalls, and so forth. And we find that the more kids go to these types of retailers, the more likely they are to have a susceptibility to tobacco. So the next analysis we're doing is whether retailer compliance modifies the risk of visiting retailers by these kids. The other thing to note in this slide is that the effects were largely seen in Mumbai, but not in Kolkata. We are seeing very differential results based on city context, where compliance measures are more consistently associated with our outcomes in Mumbai, but not as much as in Kolkata. So we think that there's some city context or social context that needs to be better understood to better understand the differential effect of neighborhood context on our outcomes. So just some take-home messages for the group here. Neighborhood access to retailers that sell tobacco is extremely high in urban environments in India. And that is something I think the government should focus on to somehow reduce or limit that amount of availability of retailers in the environment. There has to be a lot of work done in terms of improving compliance, and particularly around marketing policies and the signage policy in India. Modifying the neighborhood environment seems to be maybe an important strategy, continue to be an important strategy, particularly around retailer access and policy compliance. And policy kind of levers are a good way to go about it. And as I mentioned, city context is important to consider. So I guess the results we're seeing in Mumbai are not necessarily generalizable to the rest of the country. And we maybe need to understand other contexts, like family context, as a driver in places like Kolkata. We do find that adult tobacco use is much higher in Kolkata. So parent tobacco use is higher. So maybe there's a higher social influence in the Kolkata context and a greater neighborhood importance in the Mumbai context. I really appreciate your time and your patience today. And if you have any questions, please feel free to contact me. Here's my email address, and I'm happy to answer any questions folks might have today.
Well, thank you, Dr. Mistry, for a terrific presentation. I think this is a great example of using this extensive field research to really understand the policy impact on the ground. So fascinating presentation. So we're now going to open up the session for questions. So we invite you to turn your camera on if you're comfortable with that, to ask a question. And as a reminder, you can type a question into the chat box or use the raise hand feature and wait to be called on. And then when you're called on, you can unmute yourself and ask your question. So I'll keep an eye out for raised hands, but I see we do already have a couple of questions in the chat, so we can start there. I think one quick question, Dr. Thampi was just asking about when the study was conducted, and that may be relevant in terms of when the policy was implemented.
I apologize. I should have had that in my data. The pilot study was conducted in 2011, and then the longitudinal study started in 2018 and was completed in 2023. So there's over a 10-year period, and the environment has changed quite a bit, particularly the policy environment. And as I mentioned, the retailer policies around advertising were dramatically different when we did the pilot study relative to the longitudinal study, where in the longitudinal study, no tobacco advertisements were allowed. But when the pilot study was done, you could have 2 ads. So I apologize for not making that clear.
Okay. Yeah. No. Thanks. That's helpful. And interesting to see that. Yeah. How I expect the policy environment is not static over that length of time. So another question from Ian Sawyer about how does the popularity of different tobacco products to the U.S. affect tobacco-related cancer rates? I'm not sure exactly what the question. So, Ian, if you're online, feel free to unmute yourself and ask, clarify that question. But it looks like it's a question around different types of tobacco products.
Yes.
And I don't know if that's, yeah.
Yeah, it just popped offline. Sorry, it was confusing. So it seems like from the start of your talk, there's a lot more use of oral tobacco use, maybe? Smoking products seem to be different, filters, things like that. I'm just curious about whether the distribution of cancers, tobacco-related cancers that people develop is different. Are we seeing more oral cancers, more,
Absolutely.
more bladder? Is there any changes?
Absolutely, yeah. We see a lot more esophageal oral cancers in India relative to lung cancer rates. Yeah, so lung cancer rates are I don't think the major tobacco-related cancer mortality or morbidity in India. It's really the oral and esophageal. So you see that you see that directly in the cancer registry data, the types of cancers that you see in India because of the differential types of tobacco products used in India. Absolutely.
Okay, thanks. And another question from Teresa Eva asking, is there now a plan to track what stores sell tobacco, or is it still necessary to continue collecting that information in the field?
I think it is necessary. We don't have the funding to do that more, but we will seek more funding to do that. But I do think the Indian government at all levels could invest in tracking what retailers, who is selling and what they're selling, and if they're compliant with their rules. Some of that is happening, but it's not as consistent and systematic. As I mentioned, the number of retailers increased in our study. We didn't follow retailers, we followed neighborhoods. So we didn't go back to the same retailer twice over time. We went back to the same neighborhood twice. In the neighborhoods we went to, we did identify many, many more retailers post-COVID than pre-COVID. Our study spanned pre and post-COVID. So I think it's I was expecting actually the opposite to happen. But so I think this is a critical issue to track either from a research perspective or an implementation enforcement perspective on what's going on at the retailer level.
Okay, great. So we may have time for one or two more questions. if anyone has one, feel free to raise your hand. In the meantime,
there are a couple of raised hands I see.
Okay, sorry, I may have missed those, but
At
yes,
least
if
maybe
you have a hand raised, feel free to unmute yourself and ask your question.
Hi, thank you so much for the wonderful presentation. I had a question. Since the studies were conducted in two different time periods, did you see any newer products in the market compared to the previous years? Like we know that electronic cigarettes are currently banned in India, but like is it sold in the black market or any heated tobacco products? And currently, nicotine pouches are very popular among the school students in the US. So, have you seen any newer tobacco products in the retail stores? Thank you.
Yeah, great question. And we did look for them. And we did, even though e-cigarettes are banned, they are openly sold in Indian neighborhoods. I think particularly in the higher income neighborhoods. Not so many, but there are storefronts that advertise them with impunity and sell them. But I have not seen, but that is not true that they're not available in India, are the heat not burn products and the newer forms of pouches. I also have some anecdotal evidence that people do, especially the upper income, middle income households, they travel outside the country and they bring them in. But I haven't seen them really being sold, the heat not burn and the pouches. But that could be different because I haven't collected this data since probably 2023. So I would imagine it's going to be different now. So as new products enter the global marketplace, I think we need to continue doing this type of work. And I think there is a harm reduction potential to some of these newer products in existing smokeless and smoking product users in India. So that's a great question.
So I think we may have time for one more quick question. I think Dr. Thampi has his hand up. So feel free to unmute
Yeah, yes, sir.
yourself.
Yeah. So just want to understand one thing, sir. So why was the study location selected in Mumbai and Kolkata? Is there any specific reason?
I mean, I think I would say convenience.
Yeah.
Because when I did the pilot study, which was based on a Fulbright scholarship, I was invited to Tata Memorial Center, which is located in Mumbai. So we did the study in Mumbai, and since we had Mumbai pilot data, we applied for Mumbai as a site for our longitudinal study. And we actually had planned in earlier applications to study 4 different cities in India, 2 in the coast and 2 in the central part of the country. But we were not funded with that plan. I think partly because it seemed overly ambitious. So we chose 2, far away regions, 2 very different cultural environments and policy and governmental environments near Maharashtra and West Bengal as kind of 2 contrasting places to kind of get at the generalizability issue of our study. So I would say it's mostly convenience is what I would say, based on where our partners were. Ideally, I would like to do a similar study in the eastern part of the country, which is possible, but we haven't not planned it yet.
Great. Well, thank you. So I think we're out of time now for questions, but thank you again, Dr. Mistry, and we look forward to hearing more about where this research goes in the future. And thank you all for joining us today. So don't forget, on July 10th is our next Global Cancer Research and Control Seminar. with Dr. Mariana Chavez McGregor. So to register for this and other talks, visit our event website at events.cancer.gov/CGH/GCRCSS, URL at the bottom. To find out more about upcoming events and global health news, visit our website at cancer.gov/global-health, and also the events page link shown here. And you can see the QR code there too. Feel free to make use of that. Thank you again to Dr. Mistry and to all of you for attending today.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.